Hello, everybody. My name is Andrew Loudon. I'm an acute care and trauma surgeon who works at University Hospitals in Cleveland, Ohio. For the next 10 minutes, we will be discussing anticoagulation management in the acute care patient. I have no financial disclosures. Objectives of this discussion, we will review anticoagulation indications. We will briefly review anticoagulant medications and their appropriate reversal agents. We will discuss management of anticoagulants in the perioperative phases. The root of this talk is discussing who is anticoagulated. Probably the most common diagnosis that you will encounter is atrial fibrillation. These patients are assessed in the preoperative phase, meaning prior to the acute onset of their disease, and they're evaluated with a CHADS-VASc score. The CHADS-VASc score is calculated to calculate their yearly stroke assessment. This score is compared to their Has-Bled score to evaluate their risk for spontaneous bleeding. In their normal state of health, their risk of stroke may greatly exceed their risk of spontaneous hemorrhage. However, in the acute care phase, where the patient may be heading to the operating room, their risk assessment is now strongly weighed, where the bleeding risk is much greater than the stroke risk. Second category of patients who may present on an anticoagulant agent are those who have previously suffered from DVTs or PEs. DVTs or PEs can be categorized as provoked or unprovoked, and there may be modifiable risk factors associated with these PEs. A couple modifiable risk factors that they may bring to the table are things such as history of cancer, history of trauma or surgery, history of obesity or pregnancy, history of oral contraceptive use, history of bed rest. A couple unmodifiable risk factors would be things like inherited clotting disorders. Most common clotting disorders would be factor V Leiden mutation, prothrombin gene mutation, and protein C or S deficiencies. Understanding the pathophysiology of your specific patients, DVTs and PEs, will help you determine their preoperative and postoperative risk assessment for development of new DVTs or PEs versus their risk of bleeding. It's also worth mentioning whether the patient has had prior life-threatening episodes of blood clots. The last population that you'll encounter who may be on a blood thinner are those with an artificial heart valve. Specific questions to ask these patients would be the type of valve that they have, meaning biologic versus mechanical, which valve is involved, whether that's a right-sided or a left-sided heart valve, and this may lead to understanding of what their potential complication would be. And it goes without saying that the American Heart Association in their valve guideline does note that reversal of their anticoagulation is indicated in the setting of life-threatening hemorrhage. The medication that your patient presents on is also equally important to understand the mechanism. Probably the most common medication encountered would be warfarin or Coumadin. This is a medication that is monitored in the outpatient setting with PT-INR checks and has many interactions with other medications, and the INR will fluctuate depending on the diet of the patient. The mechanism of action is warfarin blocks the vitamin K toposide reductase enzyme. This causes a decrease in factors 2, 7, 9, 10 protein C and S production. Calculating a half-life is complicated as it relates to the most recent dose of warfarin, as well as the liver function of the patient, as well as the diet that the patient is currently on. The strategy of reversal of warfarin is to replete vitamin K factors. This can be done by supplementing vitamin K for intrinsic production of factors, as well as administering FFP or PCC to replete factors in a more expedited manner. PCC or prothrombin complex concentrate Usually contains factors 2, 9, and 10. The next category of medications, apixaban, Eliquis, or rivaroxaban, Xarelto. These are medications that work by inhibiting factor 10A. They're favored in the outpatient setting as they do not require outpatient monitoring. They're not indicated for artificial heart valves. Half-life of these medications are around 12 hours and are typically cleared in about 2 to 3 days. Reversal of these agents is accomplished by the medication Andexxa. Andexxa is a medication which increases the body's circulating factor 10A, thus rendering the medications ineffective. Dabigatran is the direct thrombin inhibitor. Its half-life is approximately 12 hours. Similarly, will be cleared in approximately 2 to 3 days. The reversal agent is atezolizumab, which is a monoclonal antibody to dabigatran. Lastly, it's uncommon that patients would be discharged on a long-term regimen of low molecular weight heparin or heparin itself. However, on the inpatient setting, we may encounter patients who are on these medications. Heparins bind antithrombin 3 to increase activity on thrombin and 10A. Low molecular weight heparins have a greater effect on factor 10A. The half-life of these medications is approximately 1 to 2 hours. And the emergent reversal agent is protamine, which is a heparin antagonist. In the management in the pre-postoperative phases, in the preoperative phase, by definition, acute care surgery is unplanned surgery. An accurate history and physical is the most important aspect of this phase. Asking the patient why they're on a blood thinner, what their underlying diagnosis is, and asking the most recent dose of their anticoagulant medication is all important. Obtaining a full set of labs, including baseline hemoglobin, to understand where we're beginning, as well as a full set of coags, including PT, INR, APTT, fibrinogen. Patient may be presenting in an anticoagulant state from their medication, but may also have DIC on board from a septic cause. The goal of the preoperative phase is to optimize the patient's clotting cascade. This can be done by stopping the medication which they're on for anticoagulation, ordering the appropriate reversal agent, and optimizing the clotting cascade based on the labs that you've ordered. Acute care surgery is often described as time-sensitive surgery. By no means should we rush to the operating room if the patient can be medically optimized. We should appreciate temporizing measures to avoid emergency surgery whenever possible. But if the patient's diagnosis and urgency for the operating room trumps their bleeding risk, the patient needs to progress to the operative phase. Once in the operating room, the number one most important thing is meticulous surgical hemostasis. After accomplishment of their surgery, making sure that the surgical bed is dry is most important. While on table, we should avoid hypothermia, as this will worsen the clotting cascade. We should keep up with blood loss, should reassess the clotting cascade throughout surgery with repeating of PT, INR, APTT, and fibrinogen. And if you're in a facility that has TEG or ROTEM, consider sending off an intraoperative TEG or ROTEM. This will help you identify other areas to optimize your clotting cascade, including administration of tranexamic acid or cryoprecipitate. If you're unsatisfied with the hemostasis at your initial operation, plan a take-back operation. This can be accomplished by placing a temporary abdominal dressing. If hemostasis is achieved at the initial operation, consider leaving drains to follow their output once the patient is closed, and then progress to the postoperative phase. In the postoperative phase, we should monitor for signs of ongoing hemorrhage. If drains are left in the surgical bed, monitor the drain outputs as well as characteristics of the drains. Should monitor postoperative labs, monitor the hemoglobin trend, although understanding that this will lag 6 to 8 hours if the patient is acutely bleeding. The next step is considering the patient's risk of hemorrhage versus their risk of complication from being off their blood thinner. If this risk assessment is strongly in favor of a complication from being off their blood thinner, starting a short-acting agent such as a heparin drip or therapeutic Lovenox would be more favorable in the event of life-threatening hemorrhage. If the patient has drains, continue to follow their outputs. These patients in their postoperative course most likely land in an intensive care unit for close monitoring from nursing as well as surgical teams. It's important to keep the patient on a short-acting blood thinner in the perioperative phase and consider returning the patient to their home regimen only when they're close to discharge. I'd like to thank SAGES for the opportunity to present. This concludes my discussion.